Good afternoon, everybody. My name is Mike Clegg. I'm Dean of the school, for those of you who don't know me. I want to welcome you to a very special lecture today. It's a guest lecture with His Excellency Dr. Thet Khin, Minister of Health in the country of Myanmar. It's a special honor for us to have you and the delegation here today. We spent a little bit of time together, and I know a little, so I was exposed to the breadth and the expertise of the group of people who are traveling with you, and I have to say that all of us are impressed with your commitment to bring such a great group of people here to Johns Hopkins. We're really honored to host you here, both at the Bloomberg School of Public Health and the university as a whole. We see this as a really historic day. According to the U.S. State Department, this is the first ministerial visit to the U.S. from Myanmar in 50 years. The visit is due in large part to the leadership of Johns Hopkins University President Ron Daniels, who is building on the efforts over many years by faculty here at the Bloomberg School, especially Chris Byrer, the School of Medicine, the School of Nursing, SICE, JPIGO, and many others. Early this year, Ron led a group from Johns Hopkins University to Myanmar to initiate an effort on how Johns Hopkins University can play a role in helping Myanmar reach its development goals, particularly in terms of the health of its citizens. This visit is the next step in building what we hope will be an enduring relationship. As we all know, it's a time of great promise in Myanmar, and the fact that a person of Dr. Thet Khin's status, training, and experience is serving as head of the Ministry of Health stands as a great symbol of that promise. Dr. Khin is a pediatrician and has served as Minister of Health since March of 2011. He did his medical training at the Institute of Medicine in Yangon and the Royal College of Physicians in London. Before becoming Minister of Health, he served as Dean of the University of Medicine in Yangon, and prior to that spent nearly 2 decades as a practicing physician. Again, warm welcome to the entire delegation, and I present to you Dr. Thet Khin, Minister of Health in Myanmar.
Thank you very much for your kind introductory words. I feel that I'm like a novice because I've been teaching pediatrics for so many years, but lately I've been engaged in a different kind of work, and I'm reading different books, which makes me more confusing than ever. But anyway, I have to do it. I would like to express my sincere gratitude to President Daniels and the faculty of JHU, as well as the U.S. government, for making this trip possible. And I appreciate all those who are present here so that we could share our experiences and views on collaboration with JHU and Myanmar. Our main purpose of this visit is to explore collaborative activities in the field of public health, as well as some disciplines in the medical field. Just now, Dean Hill advised me to keep it short and simple, what we know as a KISS formula, keep it short and simple. So when I was young, my teacher and mentor asked me to remember Begini whenever you give a talk. So it should be short enough to attract attention, at the same time long enough to cover the important parts. So I'll try my best. Our delegation strongly hope that this visit will be very fruitful, and some concrete actions will follow, either immediately or in stepwise or phase-wise manner. So we used to say in Myanmar that policy which is not followed by activity is nothing. So policy should be followed by activity, but that activity needs budget. So that's a problem. First, I would like to tell people about some uninitiated, maybe sometimes people in the West know China and India, but whenever we say that Myanmar is situated between China and India, they said near China, more confused. So it's a total land area. Myanmar has more than 600,000 square kilometers. And it's not a big country, but not a small country either, because we have a 60 million population. But the other thing is we have 14 states and regions with 135 recognized ethnic groups speaking different dialects. And geographically, we have a central plains, a dry zone, a delta. We have hilly regions in the north, the Himalayas, as well as coastal regions in the southern part. So ethnically and geographically, we are very diverse. So what happened was, after the independence, we got independence from the British in 1948, and we inherited not only the British health system, but the insurgency, because we've been, at the peak of our time, at the peak times, we have about 40 ethnic groups, ethnic armed insurgents group fighting each other. So it's about, we've been fighting for over 50 or 60 years. And the problem is, because of that, some people, they said they have a theory like a stability first, so that, prosperity second. And some think that prosperity should come first, and if the people are prosper, then they don't fight among each other. So these things still go on. So first of all, I would like to share our national health systems and what we are doing in terms of promoting health status of the people of Myanmar. We have a kind of national health policy since 4 or 5 decades ago. Since 1978, we adopted Health for All HFA 2000 as a goal to be achieved through primary health care. The highest body for healthcare in Myanmar is the National Health Committee, which is headed by myself. And the aim is to, there are two objectives: to enable every citizen to attain full life expectancy, enjoy longevity, and to ensure that every citizen is free from disease. But what happened during that period was, we've been fighting for so many years, but when the military government took over in 1988, about half of that groups had a kind of truce with our government. So the military government, what happened was, the areas under their control become the union areas. The military government had to provide more schools and the health facilities in different areas, the new areas. So what happened was, we opened up more than 600 or so hospitals in different places all over Myanmar at the expense of quality care. So what happened was, now we have more than 900 or so health facilities in Myanmar, but the quality is largely compromised by emphasizing on quantity. So what we have to do now is to improving the quality of healthcare for our people. So, and the priority health problems, I have to emphasize that the 70% of our population resides in the rural areas. So the development of a good and strong health system encompassing the rural as well as urban areas is very important. And 60% of our population is composed of mothers and children. So naturally, maternal, newborn, and child health becomes our priority. And the President himself says that the maternal, newborn, and child health is our priority at this moment. So what comes hand in hand with the maternal, newborn, and child health is nutrition, immunization, water, sanitation, so on and so forth. And as a developing country, we've been fighting with the infectious diseases like AIDS, tuberculosis, malaria for adults. For children, the major killers are not AIDS, not tuberculosis, not malaria, but the pneumonias, the diarrheas, and of course, dengue, hemorrhagic fever. And in about 50% of the children who died of these diseases, malnutrition is involved. Because, as you know, malnourished children die more easily, can get infection more easily, and die of the diseases more easily than well-nourished children. So we have communicable disease, now emerging and re-emerging disease, some people name as neglected tropical disease. We don't neglect, we have never neglected disease, but may not be on the priority list, if I may say so, not on the top priority, at the lower rung, that they are diseases. So these are now named as NTDs, neglected tropical diseases, like soil-transmitted helminths and so on and so forth, very exotic names. On top of that, what happened now in this country is partly due to urbanization and partly due to information superhighway, globalization. Myanmar people took up the habits of Western people, like fast food and these dietary changes and lifestyle changes. So what we are facing now is a rising problem of non-communicable diseases. Now the mortality is about 50-50 now. The people dying now dying from diabetes, complications of diabetes, heart diseases, strokes, cancers, and of course with urbanization we have a lot of road traffic accidents. And the other thing we have largely neglected is the environmental health and environmental sustainability. So we would like to have growth and prosperity, but not at the expense of environmental health and environmental sustainability. So what I would like to have from this the short talk is to tackle all these problems, we need to have a strong, well-trained, and well-motivated health workforce. Our universities and training schools are producing adequate number of health workforce, not only the doctors, but nurses, technicians, so on and so forth. But the quality was a bit compromised because the government cannot subsidize or support funds for the medical universities and nursing universities, because the economy, as you know, was not very good over the past 20 or 30 years, partly because of sanctions, but partly because of some mismanagement, shall I say. So the problem is now we have produced adequate quantity of health workforce because we have 14 or 15 medical and allied schools under the ministry. We have one traditional medicine university, 4 medical universities, and 2 dental universities, 2 nursing universities, and another 2 University of Pharmacy, and another 2 University of Medical Technologies. Altogether, we have 15 medical and allied universities under the Ministry of Health. So in Myanmar, there's no private medical schools as yet. So all the medical schools are under the Ministry of Health, and curriculum and standard of exam and everything is the same. We have the same board of examiners go on one university to another and take the exams. So standardization is not a difficult problem for us because all the universities, medical universities, are under the Department of Medical Science, under Ministry of Health. But up till now, they don't have the autonomy. Everything was controlled by the government. Now, with the new government's policy, economic, not only the political changes, we have administrative as well as changes in financial system also. So now we are now opening up the medical universities and institutions. I've been urging the deans and the director generals of the research institutes as well as other departments to start collaborating with universities all over the world. The bilateral ongoing programs should start initiating rather than waiting for the minister to decide or give instructions. So these are the current changes that's been happening in Myanmar. And if I remember right, there used to be a Johns Hopkins Center in Yangon that was more than 50 years ago in the Yangon University campus. But it was when all the schools and the universities were nationalized, when the socialist government took over in 1962. This the Johns Hopkins Center was also nationalized, but the agreement is still there. I think it's not the MOU thing is still there, so we can relook at it and revitalize that program also. And the other area we would like to have is the capacity building for faculty members, and also curriculum modification to meet the contemporary requirements, and improvement in teaching learning methods. Because our students still depend largely on teachers. Now, although we are preaching student-centered learning, problem-based, community-based, so PBLs and CBLs and facility-based, they still rely largely on the teachers. So we have to change their mindset also. So that's the one area we need to concentrate for our people. Because although the president and the government has changed in the political thinking as well as administrative thinking, some people, especially not only in, I don't know about other sectors, but even in my department, my former colleagues, not former, still my colleagues in the medical field, they don't, they don't really want to change. So they've been very much used to getting orders from above. So when I ask them to start thinking for their schools, for their departments, for their discipline, and sometimes, like for instance, anatomy, professor of anatomy asked me where to send her junior colleagues to study anatomy. She's the anatomist. She should know better than me. I'm a pediatrician. But so much used to asking, decision or orders from the ministers. So that's, and this is the most difficult thing is to change our mindsets. But I have told repeatedly to my colleagues that I'm asking them to change the most important thing, you know. But still, as you know, we are a fledgling democracy. Our government is only 1 year old, and our people start thinking for themselves only for a few months. So I would like to request or ask you people around the world to be patient. Otherwise, you know, we are not used to that kind of, you know, democracy or freedom or these things. So we have to do it quite nicely. You know, sometimes some elements might say that the changes are too slow, and at the same time, the other elements are saying that we are changing too fast. So I don't know who's right and who's wrong. Like half empty and half full, this cup of water. You can say that it's half empty, or you can also say that this is half full. So, but what I know is you need to educate people. People should be with us. You know, whether you go to the left or to the right or in the center. Otherwise, you know, like in the army, charge and see, and nobody is behind me. The person who said charge only charges, and that doesn't work. So in conclusion, we know that we need to intensify our work in collaboration with various partners, UN agencies, international NGOs, national NGOs, and also with various educational institutions, especially with JHU. We are hoping that during our short visit to JHU, we may identify areas for collaboration and support to our health system, especially in the promotion of public health activities, and also state-of-the-art knowledge from JHU regarding some disciplines in clinical medicine. That's why I visited Children's Cancer Center this morning. I saw, you know, very grand preparations for opening ceremony or something like that. And I saw baby rhino and mother rhino, one on the other, and it's very nice. And so many puffer fishes, looks quite good. So, and the other thing is the mechanism for collaboration and support. The President Daniels this morning told us about, you know, we should have a concrete plan following this visit. Following his last visit, the plan, now it is materialized. We as a group can come here now because of his visit in January. And because of that, our pediatrician and physician colleagues have resuscitation courses provided by JHU people. So we would like to have more of these concrete and, you know, things like further training and sustainable training and technology transfer from your university. And tomorrow we'll have cordial and collegial relationship with the faculty members of JHU on some important topics, and smoothly pave our way for long-lasting collaboration and support to Myanmar. I would like to thank you all for your kind presence and attention given to my talk. Thank you very much.
Thank you, Your Excellency. No, we're clapping for you. We can't clap. So the minister has kindly agreed to take questions. I would ask people to use the microphones at each side so we can record it. And I'll ask the first one. So you mentioned schools of medicine and the medical universities. Could you tell us about public health education in Myanmar?
I have public health specialists who know more about me than who about me on public health, but I'll give you some idea. Public health, once Myanmar was the leading country in public health in the whole Southeast Asia. So that's why the WHO regional directors, deputy directors, most of our, the WHO Southeast Asia Regional Office, the higher posts are occupied by the Myanmar people. That was 40 years or 50 years ago. And we have known all along that in our country, like in us, with very diverse and heterogeneous population and geographical areas, public health should be the top priority. And that's why we opened a new postgraduate public health school, University of Public Health, 2 or 3 years ago. But what we need is the faculty development. To have we need a strong faculty to produce a good public health specialist. And the other thing is not only public health, not only as a postgraduate or a graduate teaching, we are planning to incorporate the public health concepts in different departments and undergraduate level also. Like I'm a pediatrician, and pediatricians are the most public health oriented clinicians in Myanmar, and I don't know what's the situation here, because for a surgeon to have a public health orientation, it's quite difficult. You can't, But for pediatrician, it's quite easy. Whether you're maternal and child health, community nutrition centers, immunization, breastfeeding, everything is public health related for us pediatrician, preventive medicine and promotive. Even deworming is an art known only by the pediatricians. So, and we need a lot of the upgrading for faculty members in the public health. So, but recently, if I remember right, there's a proposal from the medical schools to have a summer epidemiology course in Johns Hopkins University for 4 or 5 students from Myanmar. That's very good, and I'm very much encouraged to hear that we need more public health specialists also, because most of the problems can be prevented at the public health level, like malaria, TB, AIDS, common childhood disorders, vaccine preventable diseases can be dealt with effectively at the community level. Some elements in the country are proposing, like introducing rotavirus vaccine to our immunization system. But for me, public health measures are much more important than a rotavirus vaccine to prevent diarrhea. So without emphasizing on public health measures like sanitary latrines, water sanitation, health education, and personal hygiene, why relying on rotavirus vaccine? But these things, we have to convince the clinicians that the rotavirus vaccine, this shouldn't be the public health priority. The priority should be the public health measures. And here, 4 of them are the public health specialists, and one's from, two of them from this university. Dr. Myen Thuy, who's got DRPH from this school. He's now the head of the ethical and research committee, overseeing all the research activities in Myanmar. And Dr. Thet Khin, she's from the alumni also. So I've brought 2 former alumni from this university purposely.
Thank you very much, Mr. Minister, for visiting our school. First, I'd like to congratulate you as being one of the very few ministers of health who, in the first 20 minutes of their talk, mentioned injuries and road traffic accidents. So congratulations, and it shows your vision. My name is Adnan Haider, and I direct the International Injury Research Unit here, and we would be pleased to explore potential collaborations with you. But I'd like to hear a little bit more about how your Ministry of Health is looking upon this burden of road traffic accidents and injuries, and what is your vision to address this issue over the next 5 years?
Thank you, thank you. It's a very important one because I once gave a presentation on childhood injury prevention at one WHO meeting. That was, I think, more than 5 years ago. I was a pediatrician at the time. The name itself is a little bit uneasy, not uneasy, but sometimes, WHO name it as VIP, Violence and Injury Prevention, VIP project. So that's, whenever I see VIP, that means Violence and Injury Prevention. We have a project headed by the professor of orthopedics from the University of Medicine in Yangon. But as you know, the injury prevention is not the sole domain of orthopedic surgeons. So this is a multidisciplinary effort. And on top of that, we have orthopedic surgeons, we have people who know about rehabilitation programs. But the thing is, these problems occur in different areas, like along the maybe highways and different regions. But we have the primary surgery or primary care is quite important. So we are conducting what we call PDC, primary trauma care. Primary trauma care. It's like more or less like a ATLS program. So we have primary trauma care program, not only for the doctors, but for nurses and the other healthcare professionals also. But we need to have a more comprehensive program encompassing all the activities. Like now we have only about 2 properly trained people working in the field of prosthetics. That's another problem. And we have laws, the road traffic laws, but the problem is enforcement. We have laws, but if we can't enforce the laws, then there's no point in amending or enacting new laws. So public health, the laws for road traffic accidents, we need to review and revise these laws also, and now we are planning to start the we don't have accident and emergency as a specialty in Myanmar yet, but with the help of AusAid and Australian government and the College of Emergency Medicine, we are going to start a program in June and to establish accident and emergency as a specialty in various, starting from the big cities, but to now and expand to various state, division, regional, and district hospitals. That's another program. And the rehabilitation is quite difficult for us. Not only the physical rehabilitation, but for incorporating these people once they are successfully treated into the mainstream society is quite difficult. And occupational, to find the appropriate occupation is quite difficult also. So we need to, if you can advise on us how to coordinate all these, we are like a piecemeal efforts. Orthopedic surgeons are doing one thing, surgeons are doing another thing. We have rehabilitation centers away from the orthopedic hospitals. So these are the practical problems to have a comprehensive injury prevention plan. Thank you.
So Minister, if by your lead, we have about 9 minutes left, and we have 3 speakers, so I'll alternate mics and go to this point and back.
Thank you. I'm interested in knowing, when you spoke of capacity building, if you have a plan for integrating the many people who have been trained along the border of Thailand to provide health care to refugees and migrant workers. Many of them are Burmese citizens originally, and some of them have fairly sophisticated training, but they're outside of your system at the moment. Is there some way that they can be integrated and given certification so they can become part of your healthcare workforce?
So thank you for bringing up this important topic. Because in Myanmar, healthcare is catered by 3 or 4 sectors. One is the government sector, taking care of more than 90%. Another one is the private sector. Another one is the healthcare catered by INGO, NGOs, and UN organizations. Maybe the fourth one by the religious organizations. But this is the fifth one, the refugee, so-called refugee camps along the border. Now, the peace process is going on very well with the ethnic minority groups. So, what we expect is in the near future, a lot of refugee camps and people might, migrate back into our country, and the doctors and health care workers working in these borders may want to join and work here. So, if it is only the registration problem or the problem concerned with the Ministry of Health or Medical Council for licensing, we can help these people to come back into the mainstream. If there is some problems regarding law enforcement or immigration laws or other areas outside our jurisdiction, then what I can do and what our president wants us to do is they can apply to the ministry concerned so that we see how we can help those people to come back and work for the people. Sometimes I'm going to meet the doctors here, Myanmar physicians here, and Myanmar president as well as myself invited them to work in Myanmar. But some people, they have difficulty in coming back. And I personally, I know that sometimes they can help more if they stay here and work here. And if they come back without any facility, as just another doctor, they can't do much for our people. Like interventional cardiologists in working in United States can come back for a vacation and teach or give lectures or hands-on skill training or 2 or 3 days. But if he left his job here and come back into the country where there's no facilities for sophisticated the interventional cardiology thing, then he would be not much help for us. So that's what I've been telling my colleagues here, that as long as they want to help our people and our country, we will find ways and means so that they can be able to do that. That's my answer. Maybe this should satisfy. Yeah, right.
Hi, Mr. Minister. My name is Ronnie Yang from Voice of America, Federal Agency of Radio and Television Broadcasting. Nowadays, there's news and reports about the occurring of some kind of immunity of anti-malaria drugs. I don't know the exact name, maybe ACT or something like that. It started from Africa. This is occurring along Thai-Burma border area and some border area. And then we also had a Ministry of Health is tackling this situation. So can you briefly explain a little bit how you are tackling? Thank you, sir.
Thank you. Malaria is the number 1 killer in Myanmar. Mortality and morbidity-wise is the number 1. And artemisinin, developed from Chiaosu, it's the Chinese drug, is the mainstay of treatment for malaria all over the world. This is not only for the uncomplicated malaria, but also for severe and complicated falciparum malaria also. So, but as you know, this drug should not be used alone. So-called monotherapy is not beneficial. So what we use is ACT, artemisinin combination therapy. So we should also use, all of us, not only Myanmar, not only Thailand, but all of us who's taking care of malaria should use artemisinin combination therapy. It's a very good drug and very safe, but nowadays we are seeing the development of resistance. You cannot prevent the development of resistance entirely, but you can delay by appropriate use of these drugs, like antibiotics. You can't prevent the resistance, but you can delay the development of the resistance. What we call is, in Myanmar, we have MARC, M-A-R-C, Myanmar Artemisinin Resistance Containment Program. It is, USAID is helping us a lot, and other INGOs and the donors are also helping us, the Global Fund and 3D Fund. So there's a problem along the, you have correctly said, along the Thai border, along the Laos and Cambodian border as well. Because this should be a concerted effort by all the partners. We have Greater Mekong sub-region along the Mekong River. So all the countries are taking part in artemisinin resistance containment program. We have to contain the artemisinin resistance from, spreading to different areas. If artemisinin resistance comes to US, those with malaria will be in trouble also. This is the currently, artemisinin is the only drug which is effective for drug-resistant malaria. So we are doing our best with the help of so many partners, right? Right.
So unfortunately, we're going to have to end because the minister has a very busy schedule, and we've been fortunate to have him for this time. I hope, though, that this is not the last time that you're here at the school, and that we can welcome you again soon. Thank you.
Thank you very much.
That was great.
You're doing a good job.